Hey everyone, thanks for tuning in. This episode is brought to you by my course, Rest Assured. If you've been struggling with falling asleep, or staying asleep, or just not waking up feeling well rested, you've come to the right place. Cognitive behavioral therapy for insomnia, or CBTI, is the gold standard intervention in the management of insomnia. Rest Assured is a digital course that walks you through CBTI, step by step, with everything you need to succeed. Each of the 6 weekly modules guides you through some important background information for the different techniques, explores the evidence based techniques in detail, provides multiple examples of exercises so you can find the one that works for you, and reviews the work you've completed since the last module. And Rest Assured is just not another DIY left to your own devices, but rather, you get direct access to me, a board certified sleep physician, in twice monthly office hours, where you can ask me face to face any questions you may have about the course material. So check out www.wellrestedmd.com/RA to learn more. That's wellrestedmd.com/RA, or just head to the homepage and click on courses to learn more. Enjoy the episode. Hey friends and neighbors, you're listening to the Well Rested Podcast, episode number 2. What is insomnia, and why do I have it? I'm your host, Dr. Joshua Lennon. I'm so grateful you decided to join me here today to discuss sleep and sleep habits and what we can do to really love our sleep again and wake up feeling better rested. But what if I told you that there's an epidemic lurking in our world that affects over half of American adults habitually, including over 10% of the population continuously for months and months on end? No surprise, I'm talking about sleep problems, and specifically insomnia. On this episode, I'll be discussing insomnia and its most common causes, including some specific things that you should talk to your trusted healthcare provider about if some of these sound all too familiar. So what exactly is insomnia? It's not quite as straightforward as some people may think. It often gets confused with a couple different conditions, and most commonly would be intentional sleep loss. So we talked about last episode, if you have insufficient sleep, that can certainly lead to a lot of the same problems as insomnia causes. But if you don't provide yourself an adequate opportunity to sleep, well, then you're going to have all these same kind of consequences. And this occurs in about 10% of adults habitually, almost every single night, not giving themselves the chance to get enough sleep. It affects about a quarter of adults half the time, and almost 50% of adults in the obesity belt or the stroke belt, which is along here in the southeast especially. And it's no coincidence that these things line up that way. Insomnia, however, refers specifically to problems stemming from an inadequate opportunity to sleep. For example, getting at least 7 hours of time in bed every single night. So as opposed to having all these consequences without enough sleep, that's something considered a little bit differently. Insomnia is when you do provide yourself that chance, an appropriate chance to sleep, and yet still have some difficulty. Now, there are different definitions, but they all follow the basics. The common diagnostic manuals we follow, one is called the Diagnostic and Statistical Manual, now in its 5th edition. This is the guidebook most often followed by the psychiatric community. And then there is the International Classification of Sleep Disorders, now in its 3rd edition, which is followed primarily by the sleep specialty community. And while there are slight differences between them, they both follow same general guidelines. Number 1, you have to have either trouble falling asleep, or trouble staying asleep, or waking up too early, or resisting going to bed at the appropriate time, or trouble sleeping without parental intervention. Now, those last two are really child-specific, and these things have to occur in the absence of medications. So trouble falling, staying asleep, including waking up too early, or not going to bed, or falling asleep without the intervention of somebody else, without the use of medications. So for example, if you only have insomnia on the nights you don't take your Ambien, guess what? You have insomnia. So number 1, you have to have that trouble at night. And then number 2, this sleep trouble leads to some kind of problem in daily function. There's all sorts of different categories that these can fall in, but in general, these would be the most common. So either we wake up when we feel fatigued or just not well rested. We have some problem with our thinking, with our cognition, and this could be difficulty with our attention or concentration, trouble with our memory, trouble with our focus. It could lead to some kind of problem with our friends, family, trouble at work, or performance at school. It could be problems with our mood or behavior, leading to changes in our behavior, such as being a little bit more impulsive or aggressive, or even lethargic or hyperactive. Which, if you've ever seen a 3-year-old who skipped her nap, then you know what I'm talking about. It could lead to problems with motivation. So if we just can't bring ourselves to do or complete something, that is one of the common problems associated with insomnia. We can be much more accident prone, stumbling, falling, accidents with the performance of a particular activity at school or work, or even with driving. Or maybe the only problem in our daily function is that we're just not satisfied with our sleep. That even if we don't have any issues with feeling awake or with our thinking or how we interact with our friends and family and how we do at work and all that kind of stuff, if we're just dissatisfied with our sleep, that also counts as a problem in daily function that could qualify as insomnia. So you have to have some kind of trouble overnight, and there has to be this daytime consequence. And so what are the things that could lead to this? Well, they really fall into a few categories. One would be medical problems, one would be mental health problems, one would be sleep disorder specifically. And then lastly, we'd have what would be considered a primary insomnia disorder. So we'll go through each one of these in a little bit more detail. So first and foremost, medical problems. These can fall into a range of issues from hormone dysfunction. So for instance, if someone is hyperthyroidic, where their thyroid gland is releasing too much of this thyroid hormone, it can be a little bit more arousable, agitated, and have difficulty falling asleep. Or maybe if you are hypothyroid, if you have not enough thyroid hormone in your system, you can feel lethargic and sleepy and tired all day long. And if that's associated with some kind of difficulty overnight, then that would certainly count as insomnia. Individuals with heart dysfunction can often have difficulty with sleep. Sometimes this can be a result of the what's called volume overload, where there's too much fluid within the blood vessels, and that can make it uncomfortable to breathe, and some other problems when we're trying to fall asleep. We see similar problems with those that have significant liver or kidney dysfunction as well. Disorders of chronic pain can often make it difficult to fall asleep, to get comfortable falling asleep, especially musculoskeletal pain is the most common. So joint, back pain, things like that can make it very difficult. And then there's the issue of autoimmune problems. These may include things like lupus or multiple sclerosis. And these kind of conditions are often associated with excessive fatigue during the daytime, sometimes excessive sleepiness as well. Fatigue more often refers to your energy level and how able you are to complete some kind of physical activity. Whereas sleepiness refers a little bit more towards your propensity to fall asleep. So if given the chance, would you fall asleep? That's sleepiness. Whereas I don't have the energy to get up and move around, that's more fatigue. And with autoimmune problems, we tend to get a lot more fatigue than sleepiness, but you can get both. And this is usually due to the elevation of specific inflammatory proteins that the body makes, that these end up being the main cause of that. But that can certainly also lead to some problems with the depth and quality of our sleep at night. So autoimmune problems are often associated with difficulty with insomnia, including a lot of the treatments for them as well can cause insomnia. And speaking of these treatments, one of the largest categories of medical issues causing insomnia would be medications. And we'll be talking about medications on and off repeatedly throughout all these episodes of the podcast, but just briefly, certain classes of medications are more likely to cause difficulty falling asleep or staying asleep or getting that good quality, satisfactory sleep at night. And these include everything from asthma medications, some heart pills, steroids like prednisone that we would often take to treat issues like immune problems, thyroid replacement hormone. If you take a bit too much, and that can certainly lead to insomnia. There are the classic stimulants, and these include everything from caffeine to the ADHD drugs like methylphenidate and the amphetamines. These are known as the brand names of Ritalin and Adderall. And then there's all sorts of problems of daytime function that we can get from the sedating effects of multiple different drugs. So these can include the quote-unquote sleep drugs themselves. These primarily fall into two main categories: the benzodiazepines and the benzodiazepine receptor agonists. That's not really all that important, but these are the tranquilizers. These are the sedative hypnotics, is another way to call these drugs. These would be medicines like Valium or Klonopin or Xanax, and then drugs like Ambien and Lunesta and Sonata. And what these drugs do is that they can severely distort the experience of the brain and the body at night with dramatic consequences. So not only are we unconscious, but we're not really asleep as a result of taking these medications. And it's the lack of that normal sleep induced by these drugs that leads to all sorts of problems during the daytime. Some of these medications are relatively short-acting, and so they're mostly out of our system by the time we wake, in terms of drugs like Ambien, for instance. And some drugs last a whole lot longer. So a lot of the benzodiazepine drugs, it can take a week for a single dose of these medications to get out of your system. And since these are primarily sedating drugs, that we can feel all of these daytime effects, from problems with motivation to changes in our mood to feeling fatigued and sleepy during the daytime, just as a result of these medications themselves. On top of that, because of what they do to the structure of our sleep at night, that even if we can fall asleep okay, that we may have trouble staying asleep, or trouble feeling like we've gotten a good night of rest, despite the influence of these medications. Then there are certain drugs that can affect specifically just certain stages of sleep, that they may reduce the amount of rapid eye movement sleep that we're able to achieve. And without enough REM, we can certainly feel poorly rested in the morning. Or more commonly, they may affect or reduce the amount of slow wave sleep, or N3 sleep, across the night. And these two stages together, N3 and REM, these should really account for about 50% of your night of sleep. And if you don't get enough of either one of them, and certainly without enough of both, you really will have quite a hard time the next day. Because loss of either one of those can cause a lot of these problems that we mentioned above, like problems with fatigue, or problems with our mood, problems with motivation, problems with our thinking and our memory. All those can stem directly from specific loss of these kind of stages of sleep. And especially if we don't get enough of slow wave sleep or deep non-REM sleep, then we're very likely to wake up a lot more often across the night. So you can get that interruption of sleep caused by the absence of this normal deeper sleep that we should be achieving. Probably the largest class of drugs that can really cause a lot of problems are medications that affect what's called the acetylcholine system in the body. These are known as anticholinergic drugs, and these anticholinergic drugs, they can fall into several different treatment categories, especially drugs used to treat bladder problems. So if you have an overactive bladder, then chances are the first kind of medicine that's going to be tried is going to block this specific hormone in the body called acetylcholine. Because when this hormone is overactive, it causes overstimulation of the muscle wall of the bladder. So if you can block that signal, then you can block a lot of the spasming of the bladder wall. And when we talk about things like side effects, this is not like some unintended consequence of a drug. I mean, these are usually what the drug does. And so in the case of these bladder medicines, acetylcholine is actually all over the body with our sweat glands and in our digestive system and in our muscles, how our nerves talk to our muscles, and of course, all over up in the brain. And so when we block acetylcholine, you can't just block it only from the bladder to stop the spasming of the bladder, but you really end up blocking it everywhere. And this can lead to problems with regulating our temperature, lead to problems with muscle aches, with cramping, with constipation, certainly, and changes in how we think and how we sleep because of this adjustment of how the brain is able to operate. So we often see problems relating to these kind of drugs. We see similar effects in some seizure medications, allergy medications. Some of the older generations of antidepressants have this strong anticholinergic effect as well. And these can both cause insomnia and especially cause a lot of daytime problems. But because acetylcholine is an activating hormone in the brain, that by blocking that hormone, the opposite of arousing in the brain is going to be sedating in the brain. So a lot of these drugs can be used off-label, meaning that they try to take advantage of this side effect of sleepiness to treat trouble falling asleep. What you end up doing is actually making the problem worse because of these medications. I think that comes from a fundamental misunderstanding of a potential side effect or a common side effect of medication versus what these agents actually do pharmacologically in the body and how they actually act and what that can do beyond just the upfront obvious side effect of any particular agent. So medications, can absolutely be a major contributor to insomnia, and especially to a lot of the daytime effects that we might attribute to insomnia may actually be due primarily to these kind of medications. Mental health problems are often associated with insomnia. In fact, until within the last decade or so, we used to call it a subclass of insomnia due to mental health problem, where the assumption was that someone wasn't sleeping well because of, say, their anxiety. That they're so anxious that they get so amped up. They get so hyper aroused and have trouble settling down, and that ends up being the main cause of their difficulty sleeping. We can see something similar with depression. With depression in particular, we can see either insomnia or excessive sleep, or sometimes both. Which makes you think, is it really the depression then that's causing the insomnia? PTSD is often associated with insomnia, and sometimes these individuals, they may have no trouble at all falling asleep, but once they start to enter dream sleep, they start to have these nightmares again, and they end up waking up in the middle of the night from these nightmares, then can't get back to sleep because they're so agitated by the trauma of that nightmare, and then they can't settle down enough to fall back asleep. So they may end up having a lot more trouble maintaining sleep across the night. And then substance use issues fall under the banner of mental health problems. So people that are taking downers, so somebody who's taking a benzodiazepine, or they're taking uppers, whether it's amphetamine-like medications, or cocaine, or other stimulants like that could really interfere with their sleep by over-arousing, over-alerting them, ramping up and waking up their body systems too much. In the case of the downers, it's because they can significantly affect the quality of sleep, so we can have difficulty there. And once the body starts to metabolize and break down these substances, then often the downers end up being, hours later, more uppers, as the body's trying to process them and get rid of them. In addition to the withdrawal that we can get from these kind of substances, often will cause insomnia as well. It's certainly what we see as being probably the number one, the main source of insomnia are not medical problems, they're not mental health problems. They're actually sleep disorders. These fall into a few different categories that we'll go over briefly today. But rather than, say, having difficulty falling asleep in the first place or difficulty maintaining sleep across the night because of some other issue, it is a problem that is specific just to sleep. Something has gone wrong in the sleep itself, and the symptom of that is the insomnia. The insomnia is the flag to alert us that there's something else going on. It's more of a symptom, not necessarily the problem itself. So the most common sleep problem that we see is sleep disordered breathing. And the most common form of this is obstructive sleep apnea, or OSA. And sleep disordered breathing is extremely common. Far more common than we thought it was 25 or 30 years ago. With older population studies, the estimate was maybe 4 to 6%, maybe 10% of the population might have sleep disordered breathing. But more recent studies, including one that was just 2 years ago here in the U.S. called the Jackson Heart Health Study, it was over 50% of southern U.S. adults. There's a study done in Switzerland within the last few years called the Hypno-Lau study, and in this study in Switzerland, where they are far healthier than we are here in America, it was over 74%. 3/4 of the adult population had obstructive sleep apnea. So it's extremely common. And most people, both the individual suffering and their healthcare providers, don't recognize it as such, and they attribute the problems to something else. So what exactly is OSA? What is sleep apnea? Sleep apnea is a problem of breathing that occurs due to the onset of sleep. As we fall asleep, we relax. Our muscles literally relax. They become less tense, they become looser. And in our airways, in the lower portion of our airway, we have a cartilage tube, or a tubing system of the trachea and the bronchial tree. So we have this hard structure, this hard permanent structure that holds everything open so air can get down into the tissue of our lungs and we can breathe. Fantastic. But in the upper portion of our airway, basically from the tip of your nose down to the Adam's apple, and women have one too, it's just a lot smaller, but that entire portion of the upper airway is held open just by muscles. There's not some firm, hard structure that's always going to maintain the openness of the hole through which we breathe. It's muscle. And so as we fall asleep, just like the muscles in our back and shoulders and arms and legs will relax, as we fall asleep, these airway muscles end up relaxing as well. And so when the tongue relaxes, or the soft palate relaxes, or the walls of your throat relax, if they relax a little bit too much, they can start to collapse inward a little bit. They can cave inward towards each other, making the size of that pipe of your airway a little bit smaller. And sometimes a lot of it smaller. And sometimes it collapses completely. But most people that have sleep apnea, most of the problem they experience is the result of a partial reduction in the size of the hole of their airway, rather than a complete collapse. Sleep apnea literally means no breath. But most people have a partial reduction here. And so what happens is we fall asleep, the muscle tissue relaxes, it starts to narrow the caliber of our airway. Because there's less space, we can't pull the same volume of air through that more narrowed airway. So less air now reaches the pipe of the trachea and the lungs. And with less volume of air reaching the lungs, your lungs can't extract a sufficient amount of oxygen to maintain the saturations in the body. And this leads to increasing efforts to try to breathe. So we try hard and try harder to try to pull in more and more air. And it's both the increased effort to breathe and these changes in our blood gases, both oxygen getting lower and carbon dioxide getting higher, that triggers an arousal. It forces us to wake up. we get the sympathetic nervous system activated, the fight or flight system activated. So we get a surge of stress hormones, norepinephrine, epinephrine. And once these stress hormones go through the bloodstream and they reach your brain wakes up. And what happens when your brain wakes up? Your muscles wake up as well. So now we've regained the tension in the muscles all over the body, including in the throat and the airway. So now we've got a big wide hole to breathe through again. So we can normalize our blood gases and everything gets back the way it's supposed to be. And that only takes just a couple seconds, 2, 3, 4, 5 seconds. We take some good healthy breaths and then we fall right back asleep. Just like that. We're not even aware that we had woken up. It is so brief, but it's life-saving. We fall back asleep, and as we get deeper into sleep and our muscles relax further, the problem happens again and again and again and again and again. And so sleep apnea causes insomnia because in an effort not to die from choking on our own throat, the body wakes itself up in this last-ditch effort to stay alive. And yes, we do stay alive. People very, very rarely die in their sleep from sleep apnea. It certainly happens, but not very often at all. But there are major consequences to this. Both the problem of blood oxygen causes damage. The arousal response itself, the stress response, is damaging to the body. And then, of course, the interruption of sleep is problematic as well. And so not just insomnia, but all sorts of issues related to vascular disease and heart disease and stroke and dementia, several different cancers, all sorts of problems related to sleep apnea. But certainly insomnia is one of the most common symptoms of sleep apnea. In fact, there was a recent study published right at the end of 2019 where they looked at all of the patients referred to a sleep center for primary insomnia. It was over 1,600 individuals. About 2/3 of them were women. They were normal weight. These are not overly thin or overly obese. They tended to be in their mid-40s, and they had about a 10-year history or so of insomnia. And when they were actually tested, when they actually went through a sleep study, over 88% of these individuals that were referred just for insomnia, no suspicion of sleep apnea whatsoever, once they were actually tested objectively, almost 90%, almost 9 out of 10 were found to have sleep apnea. And the only symptom they had of that, the only main symptom they had was the insomnia. That both the patients themselves and their referring primary care doctors, they thought there's no way that these people have sleep apnea. They only have insomnia. So we're sending them to the sleep providers for their insomnia. But once they're tested, the overwhelming majority of them have sleep apnea. And so insomnia is definitely a very, very, very common cause of insomnia. Another common cause is something called Willis-Ekbom syndrome, or is also known as restless legs. They're trying to get away from that name, restless legs, because it's not just the legs that are affected. Certainly, arms and torso and neck and all sorts of parts of the body can be affected by this. And on average, it may affect anywhere from 10 to 15% of the population, give or take. A little bit higher in some populations, a little bit lower in some populations. So what is restless legs? By definition, this really causes problems falling asleep. Restless legs is what happens when we feel this not necessarily painful, but uncomfortable sensation. Some might describe it as a weird tickle, or like bugs crawling, or pitter-patter on the surface of your skin. It's just this very irritating sensation, typically involving the legs. And as a result of this sensation, we feel an urge to move or wiggle, to get up, to flex, to stretch, to rub our legs, to rub our arms, to move around a little bit. And the act of moving around, getting up and walking, rubbing, that activity alleviates this weird sensation. But only temporarily, because as soon as we sit back down, as soon as we're still, as soon as we stop moving, often that sensation comes right back again. So this is very, very agitating. And it tends to occur most often just in this short period of time right before we are expected to fall asleep. So you can imagine feeling totally comfortable all day long. You have dinner, you finish up whatever you need to do at the end of the day, you get ready for bed, and then as soon as you climb into the sheets, now you have this agitating sensation in your legs or in your arms. And it's so aggravating. You have to get up out of bed, stretch your legs, move around the room. And when you do that, you feel better. You think maybe you got it taken care of, you climb back into bed, and then it just comes right back. And over and over and over and over and over again. And so it's really hard to fall asleep when you have restless legs. We can talk about restless legs in more detail later, but that is a very common cause of difficulty falling asleep in the first place. And restless legs, by definition, occurs when we are awake. It's not something that's really interrupting our sleep or having us or causing us to have difficulty maintaining sleep across the night. But absolutely, trouble falling asleep is one of the hallmarks of restless legs. We can have problems with our body's internal clock, what are known as circadian disorders. So if there's some misalignment between your internal clock and the external clock, then you can definitely have trouble falling asleep or trouble waking up at the right time. And the classic example is jet lag, that if you live, say, in New York City and then you travel to London, there's about a 6-hour difference there. And so your body's really confused about when it's time for lunch or when it's time to go to sleep or, when it's time to go to the bathroom. And so this misalignment between your external environment and what your body's internal clock is telling you will often lead to these kind of troubles. Our body's clocks, they can be either delayed in relationship to our environment or advanced, coming too early in relation to our environment, or they can be totally irregular. And we see this a lot with brain disorders, especially degenerative brain disorders, or those that have poor or absent sight, because light is one of the strongest cues, the strongest triggers that helps to maintain the alignment of our internal clock. So people that suffer blindness, especially retinal blindness, are the most prone to have these kind of disorders. There are problems called parasomnias, and these are basically behaviors overnight. So this wouldn't cause any trouble falling asleep, but certainly trouble maintaining sleep across the night. If you get up and sleepwalk, is sort of the classic parasomnia, or sleep eating. You get up, you go down your kitchen, and you start eating, and then the next morning you have no recollection that this has happened, but because you were partially awake across the night, you might feel really tired the next. You might have all these same daytime consequences from the interruption of your normal sleep. And then there are problems of sleep hygiene, which we'll be addressing in a lot more depth over the next 4 episodes or so of the podcast. But this can relate to inadequate opportunity. So this insufficient sleep would be considered troublesome sleep hygiene. If the environment in which we're trying to sleep is too wake friendly, meaning that if it is too bright for our sleep, too noisy to sleep in, or if it's too warm to sleep in, that kind of environment is just not conducive to the onset of sleep. So that's a common cause of insomnia symptoms, is having this environment that is not really appropriate to sleep in. Then, of course, there's all the ingestibles. If we have caffeine too late in the day, then this is a stimulant, so that's going to keep us awake. Alcohol consumption can absolutely do too. And this can be a little bit confusing because alcohol is sedating, and so a lot of people will take a little nightcap to put themselves to sleep. But again, it's easy to confuse sedation with sleep. And the sedating effects of something like alcohol are not the same thing as actually putting you to sleep. So it can severely disrupt the kind of sleep that we would be achieving. And on top of that, within 1 to 2 hours or so, as your body starts to process the alcohol and try to detox, that the results end up being really, really, really agitating. That now we have all these alerting substances in the body. These breakdown products of alcohol actually end up being much more arousing. So it severely interrupts the continuity of our sleep for the rest of the night, even though it was sedating at the beginning. And then nicotine, kind of like caffeine, is another stimulant. So even if you think having that last cigarette of the day right before you go to bed helps you to relax, this is another area where we are confusing the satisfaction of an addiction with relaxation. That we are agitated because we need that next cigarette. And because we've satisfied that need, now the agitation has gone down a little bit, but that's not the same thing as actually relaxing you. That nicotine, this substance itself, no matter what you think, is stimulating. And when you have nicotine, whether in the morning, middle of the night, late at night, early in the afternoon, doesn't matter. Nicotine is stimulating. And so if we have a stimulant too close to when we're trying to go to sleep, it's going to interfere with our ability to fall asleep and certainly to maintain sleep across the night. So these kind of things can absolutely affect our ability to fall asleep and stay asleep. Our activity levels during the daytime also fall within this rubric of sleep hygiene. The more sedentary that we are, the more likely we are to have insomnia. The more active we are, the greater our sleep drive becomes, the easier it is to fall asleep, and the easier it is to get good quality sleep, especially that deep, slow wave sleep, the more active we are. So when we are at a desk job all day, we sit in the car on our commute, we sit at home on the couch, and we're really not moving around or being active that much during the daytime, that is a common cause of insomnia. And so sometimes just being more active is all it takes to address that, which we will. I believe in episode 6, we'll be talking specifically about activity. And it's not just physical activity, but even social activity, cognitive activity, things that make you think more. That kind of activity as well makes it easier to fall asleep and stay asleep. And then lastly, we have this large category of what sometimes is called primary insomnia, or insomnia without some other easily identifiable cause, like another sleep disorder or a medical problem or medication. And this really happens because our thoughts, our judgments, our actions and behaviors, these end up resulting in habits that can interfere with our ability to fall asleep and to stay asleep. A classic example is mind racing. And this can occur with or without anxiety. It doesn't have to be distressing, but people often say that they have trouble turning off their mind at night when they're trying to settle down, they're trying to go to sleep, and it's just one thought after another nonstop. And sometimes it really is distressing that they are anxious, that there is something that's really worrying them, that's keeping them awake. But a lot of times, it's not. It's random noise that just keeps filling the void of our minds. And this has to do with what's called the default mode network, or the DMN. The default mode network is basically a network of different parts of your brain that kick in whenever we are not focused on one particular task. And the default mode network tends to involve issues of the ego. We tend to fill our thoughts with me and I and what people think of me and what I'm going to do and how could she say that to me? It's me, 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 me. Or threats to me. So these issues of anxiety, how are they going to affect other people? How are they going to affect me specifically? And so whenever we're not focused on one thing or another, whenever we don't have directed activity, by default, the default mode network kicks in. And sometimes even when we intend to do something different, like I crawled into bed, I crawled into the sheets, my head is laying on the pillow, I want to be sleeping, and yet the default mode network is taken over and just filling my mind with thought after thought after thought after thought. Now, certainly something like this kind of insomnia is a lot less dangerous than the life-threatening issues, say like sleep apnea, or even all the dangers that can come along with something like restless legs. But actually is the simplest thing to fix. Simple does not mean easy. This is certainly one of the hardest to implement, but it is rather simple. Unfortunately, this is also the least likely to be adequately addressed by healthcare professionals, in medicine specifically, not behavioral specialists. Because what's going on is that we engage in some pattern of thought or action, behavior. Patterns become habits. Habits become automated, even without any intent or desire. So by default, you may be falling into these automatic behaviors with automatic thoughts that you feel out of control of. So the most effective way to resolve this type of insomnia is to identify which automatic thoughts and behaviors you are experiencing, and then replace them with thoughts and behaviors that are healthier, that are directed, that are intentional, that allow you to sleep more soundly and wake well rested the next day, that allow you to be in control of your own mind and not feel dragged along by these automatic thoughts of the default mode network, that allow you to thrive. So I'll be discussing a lot of the above repeatedly and in more detail in future episodes. But if you're having trouble with insomnia now and you're not feeling well rested, please do bring this up not once, but over and over again with your most trusted healthcare providers so that the appropriate investigations for some potentially dangerous medical and sleep disorders can be completed and to get you on the correct treatment to reduce your risk. But if you've been down that road before, you've had a sleep study, or all these tests have been done, and all you got from your doctors was, quote, everything was normal, please stay tuned, because I've got lots of great stuff that's just for you. So be sure to hit subscribe in your favorite podcast player to get all the latest episodes. Leave us a review, and head on over to wellrestedmd.com for more information. Thanks for listening.